Welcome to the EMIG presentation. And today we would have Dr. Aniaka Tessin, a medical officer who will be presenting to us. So I'd like us to welcome her with claps in the chat box or with reactions. Dr. Aniaka Tessin, you're welcome.
All right. So thank you very much, Dr. Thank you everyone for joining today's case presentation. Please let me know if you can hear me very well, just a reaction, a thumbs up or something. All right. Okay, so I'm very excited to be presenting this interesting case today. For those of us that have been in medical school, we know that diphtheria is one of those things we hear, but it's not something you frequently see in the emergency room or in the pediatric ward. So I'm excited to be presenting the topic diphtheria outbreak in the emergency room, lessons on airway rescue and infection control. This case presentation was supervised by Dr. Emmanuel Okegwale. He's a senior registrar, now consultant at the University of Benin Teaching Hospital. He would try to join the presentation if he can. He has said that, so hopefully we would have him. Thank you so much once again. All right. Okay, so what is the emergency medicine relevance of this case? It's important to mention that the case aims to show us the importance of airway management in infectious emergencies. Like we had with coronavirus and very infectious respiratory diseases, the essence of airway management becomes clear. So airway management in infectious emergencies is a priority now. And so it goes to show the importance of mastering airway rescue techniques in low resource settings. It also highlights the importance of infection prevention and control in the emergency department, particularly in low resource countries like ours, where we have emergency units that are poorly ventilated with high patient turnover. So we want to be able to discuss the importance of strict triage protocols, the importance of having an isolation ward within the emergency room, and the importance of having available materials, personal protective equipment for healthcare workers in the emergency department. It also shows the role of emergency physicians as the frontline epidemic detection and response. We are aware of the medical doctor who gave herself for Ebola virus. So it shows that emergency physicians or medical officers in the emergency room or emergency room health staffs are the front line in epidemic detection because they usually come in through the emergency department. And you need to have a high risk of suspicion while managing cases in the emergency department. And finally, it goes to show the importance of simulation-based training in airway management under infectious conditions. Apart from being taught how to manage the airway, there has to be a room for us to learn what to do when you have a patient that is highly infectious and the steps you need to take to protect yourself and, of course, other patients there. So I'll be going straight to the case presentation. So I'm presenting a male, 10 years old, who was admitted on the 8th of June, 2024 at the Children Emergency Room, the University of Benin Teaching Hospital. The duration of stay was for 8 days and the informant was the mother. He presented via a verbal referral from a private facility to the Children Emergency Room with a complaint of cough of 8 days, neck swelling of 5 days, hoarseness of voice of 3 days, fever of 2 days, and difficulty in breathing of 6 hours duration. The cough was described as initially dry, however, became wet 2 days after onset, sometimes productive of clear, thick, non-copious, non-foul smelling sputum, non-backy, non-paroxysmal, not distressing. There was no associated post-tussive vomiting, no history of contact with any chronically coughing person, and it persisted until presentation. The neck swelling was noticed 3 days after the onset of the cough and catarrh. It was gradual in onset, involving the right side of the neck, and it progressed to involve the left side a day later. There's associated history of noisy breathing, associated difficulty in swallowing, and later there was pain on swallowing that progressed from solids to semi-solids, and later patients could only tolerate liquid meals with marked difficulty. There was no swelling in any other part of the body, no history of trauma to the neck, no history of insect bites. The neck swelling gradually increased in size until presentation. 5 days after the onset of the cough and 2 days after onset of the neck swelling, patient presented with hoarseness of the voice. It was said to have changed and become rusty. It gradually worsened 2 days after onset and as patient was no longer audible. It persisted until presentation. There's associated history of occasional blood-stained nasal discharge. There's no otologic symptom. Patient also presented with fever. Noticed 2 days prior to presentation. The body was said to be very hot. It was transiently relieved by tablet paracetamol. Persisted until presentation. Associated malaise and anorexia. The difficulty in breathing was noticed 6 hours prior to presentation. Noisy breathing, severe enough that patient could not complete a sentence. And this was what made the patient to present at our facility. Following onset of cough at home, he was given cough syrup and loratadine by his parents. But his parents took him to the referring hospital because of the neck swelling and hoarseness of voice, where he was admitted with 2 of his siblings who had the same symptoms. He was referred to UBTH on parental requests because of the onset of difficulty in breathing and because of the demise of his younger sibling from the same symptoms. There's no history of previous hospital admission, no surgery in the past, no blood transfusion in the past, no known drug allergy. He's completely immunized for age according to the NPI schedule at the primary healthcare center. However, immunization card was not cited. He will not delayed developmental history. There was no delayed developmental milestones. He worked at 14 months. He's currently a primary 5 student at a private school. The mother is unsure of how many students are in the class, and he has not been to school since the onset of the illness. He's the second of 3 children in a monogamous family setting. The first child is female, 12 years old, alive and currently on admission, who was currently on admission for the same symptoms. The third child is a male, 4-year-old, who died from similar illness in the referral hospital. The mother is a 38-year-old trader with secondary level of education. Father is a 40-year-old trader with tertiary level of education. They reside in a 3-bedroom apartment, sleeps in one of the rooms with his siblings. Source of drinking water is sachet water. Sewage disposal is water system. On examination, we had an acutely ill-looking child in respiratory distress, anxious with drooling of saliva. He was febrile with a temperature of 38.3, not pale, anicteric, acyanose, dehydrated, had diffuse neck swelling. There was no pedal edema. On respiratory system examination, the respiratory rate was 38 cycles per minute. SpO2 was 75 to 80% in room air. It improved to 86% on oxygen via face mask. Inspection of the chest reviewed subcostal and intercostal recession alongside paradoxical abdominal movements. The chest wall was symmetrical. Percussion note was resonant. On auscultation, there was the air entry reduced bilaterally with inspiratory stridor and quiet breath sounds. On examination of the oropharynx, there was pooling of saliva in the oropharynx, extensive grayish yellow pseudomembrane over the entire pharynx and tonsils, with blood oozing from the lateral aspect. The pseudomembrane extended to the proximal hard palate. There was also purulent discharge over the medial border of both tonsils. The abdomen was full, moved with respiration, no area of tenderness, no ganomegaly. The bowel sounds were normal active. So this is just a diagram of what the pseudomembrane looked like. This is the pseudomembrane covering. You can also see it here, the pseudomembrane extending. So in some cases, you can have it occluding the airway totally. This is not a picture of our patient. This is just for reference sake. On cardiovascular system examination, the heart rate was 108 beats per minute, irregular normal volume. Blood pressure was 160. Apex beat was 5th left intercostal space, mid-clavicular line, heart sounds 1 and 2 were heard. On CNS examination, he was conscious, he was alert, people's equal reactive, other cranial nerve examinations normal, other CNS examinations were normal. For this patient, we did some investigations while he presented. A full blood count showed leukocytosis, anemia, and moderate thrombocytopenia. A throat swab MCS was collected and sent to the microbiology lab where it revealed gram-positive bacilli, and the culture yielded growth of normal flora after 48 hours, likely from contamination. We had a normal EUCR. MRDT was negative, and we did an ECG. I'll explain why we needed to do an ECG later, which showed right bundle branch block and right axis deviation. So the diagnosis for this patient was suspected respiratory diphtheria. Because this patient presented in respiratory distress, the patient was placed in an isolated room in the emergency room. The attending medical officer suspected a case of diphtheria with the history of the patient having one of the siblings having died in the referral center, and the bone neck swelling and the pseudomembrane over the tonsils. So he was placed in an isolated room in the emergency room. He was placed on 5 liters of oxygen via a face mask. A consult was sent to the ENT surgery unit for an emergency tracheostomy in view of impending upper airway obstruction. Remember that the patient was saturating at 86% despite being given oxygen via face mask. So because of the possibility of an upper airway obstruction, the ENT surgeons were contacted for an emergency bedside tracheostomy. An IV line in situ was placed, and the patient was placed on IVF 4.3% dextrosaline and 100% maintenance. We had a consult also sent to clinical microbiology because we needed them to come and take the samples themselves. I want to add that at this point, the WHO surveillance team for diphtheria was also contacted. So for the emergency tracheostomy, a bedside emergency tracheostomy was carried out by the ENT surgeons. So my chief that is here today is supposed to talk briefly about emergency bedside tracheostomy. So I think he will do that at the end of the presentation for anybody who has questions. The procedure was carried out under local anesthesia with the patient there. Immediate post-tracheostomy care was given, which is he was nursed opposite the nursing station in view of the nursing station. A bell and writing pad was placed beside the patient. They ensured humidified oxygen and regular suction. An emergency tray was also placed at the bedside in case of the patient going into an obstruction or a hematoma forming. So this is just a simple diagram of what the tracheostomy is. So an incision is made around the second tracheal ring with the tracheostomic tube to divert the obstruction in the upper airway to enable the child to be able to respire well. Child was also placed on IV amoxicillin, clavulanic acid at 90 milligram per kg per day in 2 divided doses, placed on IV metronidazole at 7.5 milligram per kg per dose, 8 hourly. Was also placed on fluids. The most important thing to mention here, he was given diphtheria antitoxin at 80 international units, placed into 250 ml of normal saline infusion over 4 hours. This is one of the most important things to give in diphtheria. He was also given hydrogen peroxide to gargle 3 hourly. Now, the importance of giving the hydrogen peroxide is that the oxidative action of the hydrogen peroxide breaks down the debris and enables the thick adherence of the pseudomembrane over the tonsils or the larynx or the pharynx to come down so that it does not cause upper airway obstruction. It also helps to reduce the bacterial load so that the rate of transmission is reduced. That's the essence of the hydrogen peroxide gargle. On the 2nd to 5th day on admission, the child was receiving intravenous antibiotics as prescribed. He had an emergency tracheostomy in place. He had already received the diphtheria antitoxin at the 8th hour on admission. The patients were given oral erythromycin. All health workers who came in contact with the patient were all placed on oral erythromycin. He was neck swelling and the hoarseness of voice had started subsiding. The respiratory distress had also started subsiding. The patient was now able to tolerate orally. The WHO team reviewed him on the 4th day of admission. Remember, we had sent them a message on the first day. The elder sibling, who was also referred along with him, was doing stable. And then the ENT reviewed the tracheostomy on the 5th day for a trial of decannulation. That's the trial of decannulation is where from morning till, let's say, evening, they would take out the tracheostomy tube or they will seal it. They will seal the hole and see if the child can tolerate breathing through the normal parts for 12 hours. And if the child is able to tolerate, then they now progress from there. But if not, then they would have to put it back or open the tube or open the point of the tracheostomy. On the 6th to 8th day of admission, the ENT team reviewed him and decannulated on day 6 because he tolerated the trial of decannulation. All exposed health workers were placed on erythromycin. The patient was discharged on the 8th day and was referred to the infectious disease clinic for follow-up after 1 week. So thankfully, this was the patient survived in this case. So let me discuss this case. So for the case discussion, so diphtheria is a severe bacterial disease that is caused by Corynebacterium diphtheria. And Corynea means club-shaped. The bacteria is a gram-positive, non-spore forming. And one of the characteristics of diphtheria is that it forms an adherent pseudomembrane over the pharynx, and these can result in upper airway obstruction. Before toxins were discovered in the 20th century, it was called the strangling angel of children and was a significant cause of mortality in children and adults. The Corynebacterium, like I mentioned, is gram-positive rod. There are 4 types. You have the Mitis, Intermedius, Belfanti, and Gravis. The most common of them, the one that we frequently have or see in most epidemics, is the Mitis. However, the severity of the disease they cause, Gravis causes the most severe disease. So this is just a picture of what the Corynebacterium looks like. So the incidence of diphtheria has reduced dramatically worldwide. Over the past 5 decades, we've had, because of the widespread DPT vaccine, diphtheria, pertussis, tetanus vaccine, we've had very low cases. According to the WHO, since 1980 to 2021, we have a drop in cases from 100,000 to 10,000. But recently, the WHO surveillance report has indicated that we are now having cases of diphtheria, especially in the African and Southeast Asia. And worldwide, the vaccination rate is about 80%, but there are still outbreaks of diphtheria where you have a density of unvaccinated individuals in one or more locations. So we are having a decrease in herd immunity. So you have more people coming down with the disease. The number of reported cases of diphtheria have declined also in Nigeria. As at 1989, we had like 5,000 cases. By 2006, we had just 312 cases. Well, recently we've had more outbreaks. In 2023, we had a number of cases and deaths. For example, Lagos had 5 cases and 3 deaths. Kano had 100 cases and 32 deaths. In 2024, which is last year, we had about 6,518 confirmed cases. That's a long way coming from 328 cases in 2006 and 839 deaths. This just shows us that there's a resurgence of diphtheria and people need to start taking the infectious disease more seriously. Majority of the confirmed cases of diphtheria are among children, so it's more of a pediatric thing. We have seen that only 25.2% of the people who had confirmed cases were actually vaccinated with DPT vaccine, and a total of 598 deaths were recorded among the confirmed cases. This is just an age distribution from the CDC website that shows the breakdown of confirmed people that are vaccinated and those that were not vaccinated that were affected. It's just a reminder to show that this is a vaccine preventable disease, but for whatever reason, we have low uptake of vaccines now. So the factors that contribute to this epidemic are this large population of under-immunized adults. So people that they received maybe the first dose and they didn't go back for the next doses. We have decreased childhood immunization rates. Another very important thing is the conflict and climate-induced migration in Nigeria with the new onset of a lot of IDP camps. You have children who should have been vaccinated missing out their vaccines. So this has contributed to the large population of under-immunized and unimmunized people. You have overcrowding and failure to respond aggressively during the early phases of the epidemic. So cases where you have people that do not present early or present early, but the diagnosis is not made on time. This disease, I want to state that humans are the only reservoir of C. diphtheria. And this is quite important because for healthcare workers who come in contact with a patient who may be a carrier, you may inadvertently also become a carrier and spread it to other patients. It's possible to be an asymptomatic carrier of C. diphtheria. So the infection is acquired by contact with a carrier or an individual with the active disease. It can be gotten via respiratory droplets. So coughing, sneezing, talking is going to transmit the bacteria. Average incubation period is 2 to 4 days. The primary focus of infection is mainly usually the tonsils or the pharynx. For asymptomatic carriers, you may be an asymptomatic carrier if you have immunity, either a vaccine-induced immunity or via a natural infection. So you be a carrier, that means you will still transmit the disease to others. So for the pathogenesis of this infection, the pathogenesis is quite simple. Diphtheria produces an exotoxin. So what is responsible for what we are seeing in diphtheria is the toxin, which is why the antitoxin is one of the most important things to give. So the toxin is an exotoxin, and like all exotoxins, they have the A and B subunits. The A is the active part of the toxin, the B is the binding unit of the toxin. What diphtheria does is that it goes into the cell. Once it gets into the cell, the active part of the toxin, like that we can see here, is going to inhibit elongation factor 2, which is responsible for translation of mRNA to proteins. So inhibition of this ribosylation process would prevent protein synthesis and result in cell death. So that cell death, accumulations of necrotic cells, the bacteria itself, and white blood cells is what forms what is known as the pseudomembrane. You can think of it like a granuloma that is forming. So that's what forms the pseudomembrane that adheres to either the pharynx or adheres to the larynx and is responsible for the upper airway obstruction that is seen in diphtheria. This is just a simple sketch of what the pathogenesis of diphtheria looks like. Of course, the most common diphtheria is the respiratory diphtheria, and it is what we are most worried about. The signs and symptoms, of course, depends on the site of infection and the immunization status of the host and whether the toxin has been distributed to the systemic circulation. So for respiratory diphtheria, it usually occurs within 2 to 4 days with contact with anybody who has the virus, who has the bacteria, sorry. So initial symptoms are just like we saw, a patient presenting with cough, runny nose, so sore throat in some cases, red eyes, fever. Those are the initial symptoms of diphtheria, which is why it's now advised that if you see a child who is presenting with cough, runny nose, fever, it is important to look at the throat of the child, and please do so while wearing a face mask. In severe cases, the bacteria would produce the exotoxin. So for some people, they may just end up in that initial phase of cough, runny nose, sore throat, and red eyes. But for some, the bacteria produces an exotoxin, that is in severe cases of the disease, and that causes the thick gray or white patch that is found over the uvula, the soft palate, the oropharynx, the hypopharynx, and causes the upper airway obstruction that is seen. The diagnosis of diphtheria is based on clinical findings, because if you want to delay and wait for any process to initiate treatment, it can compromise the patient, like our patient who was delayed at the referral hospital and was brought in days later. And so by the time he presented, he was in upper airway obstruction. So the diagnosis is usually, we have different types of diagnosis. You could have the culture where a low-flash slant, a sterilite plate, there's inoculation of the media of the bacteria into this media, and if C. diphtheria grows, then it's characteristic of it. The other kinds of tests are, you have the modified ALEC test, the PCR, which is going to assess for the DNA of the diphtheria. So when do we say this is a suspected case of diphtheria? Anybody with an illness of the upper respiratory tract that is characterized by pharyngitis, nasopharyngitis, tonsillitis, laryngitis, with an adherent pseudomembrane. And the important thing to note is that the pseudomembrane, attempts at scraping off that pseudomembrane would cause severe bleeding. The person will begin to bleed. So that is a suspected case of diphtheria. A confirmed case is when you have a culture positive for the toxin production, regardless of whether the person has symptoms or not. So mild forms of nasal diphtheria may resemble the common cold, like I said. For instance, some people frequently are saying, oh, have you noticed people are having common cold frequently? A lot of people are having common cold frequently. They suspect it's maybe a resurgence of coronavirus. It may be diphtheria, and it's important for you to know that as a medical officer or as an emergency physician. Also, we have other kinds of diphtheria, tonsillar or pharyngeal diphtheria, which should be differentiated from strep pharyngitis because strep pharyngitis has more severe pain, the fever is very high, and you don't have any membrane that is adherent to the tonsils. Other forms of diphtheria is the tonsillar and pharyngeal diphtheria, which you should differentiate from infectious mononucleosis. Infectious mononucleosis has lymphadenopathy and splenomegaly, which are common features seen in them. So these are some differential diagnoses of diphtheria. The treatment of diphtheria, the antitoxin is the mainstay of therapy and should be administered. And the antitoxin as a single empirical dose of between 20,000 to 100,000 units. The role of giving an antibiotics is to halt toxin production. So while the bacteria is there, the bacteria is producing toxins. So the mainstay of treatment is to eradicate that toxin, and then at the same time, you want to you want to give antimicrobial therapy for the bacteria that is present. So usually erythromycin or penicillin is recommended. Elimination of the organism is documented when you have at least 2 successive cultures of specimens from the nose and throat obtained 24 hours after completion of therapy. The WHO recent guidelines released on the 2nd of February says that the severity of the disease is classified as a mild disease that is just localized to the pharynx for 2 days duration. But it is called a severe disease once you have diffuse neck swelling or respiratory distress and hemodynamic instability. For our patient definitely had a severe disease. The principle of management is simple. Neutralize unbound toxin with diphtheria antitoxin. Antibiotics should be given to prevent further growth of the bacteria, toxin production, and reduce bacterial transmission to others. And then you should prevent and treat complications. So the diphtheria antitoxin, the standard of care for treatment of diphtheria cases, it is known to reduce mortality by 76%. So if you suspect any case of diphtheria, if you do not have a diphtheria antitoxin, you should refer immediately to a place that would have a diphtheria antitoxin. And if you are working in a teaching hospital, it is advisable to request for a diphtheria antitoxin to be in stock, especially now that we are having frequent outbreaks. So the diphtheria toxin is the most effective in neutralizing extracellular toxins. The dose to be given is described as if the person has laryngitis or pharyngitis for less than 48 hours, you give 20,000 international units. If the person has a nasopharyngeal disease, that is a pseudomembrane, but it is less than 48 hours, you give 40,000 international units. Now, if the person has diffuse neck swelling or any disease that is beyond 48 hours and is resulting in respiratory disease, is causing shock, then the patient should be given 80,000 international units. Our patient received 80,000 international units because of the diffuse neck swelling, and of course, the presentation was late. For antibiotics, like I mentioned, we use macrolides, and azithromycin or erythromycin are the drug of choice. For penicillin, you can also use penicillin also. But this is a sensitivity profile from the NCDC in Nigeria, just showing what our own sensitivity to diphtheria looks like, antibiotic sensitivity. And they found that erythromycin, of course, was 90% sensitive in most cases. So as a healthcare worker, if you are ever exposed to a suspected case of diphtheria, you should take erythromycin. That is the hack from today's presentation. So close contacts for the patients should be monitored for signs and symptoms. Ideally, we should have done a contact tracing, but then We reported it to the WHO, so we expected the WHO to follow up from there. So they are supposed to do a contact tracing to the boys' class, especially since all three of his siblings were affected and one had died. So they will do a contact tracing to his school, to his siblings' school also. So that's the mainstay. Another thing is the prophylactic antibiotics that is indicated for 7 days for anybody who has had close contact with somebody who has had diphtheria. Like I mentioned, the drug of choice is erythromycin. There's other supportive management because of the complications of diphtheria. So we require bed rest, serial ECGs to be obtained. I'll explain why later. Bed rest is necessary because of the myocarditis that can cause sudden death in these people. Hydration, suction the secretions to prevent aspiration. You should check for gag reflex and the quality of their voice as the disease progresses. And once the patient recovers, patient should be immunized. One of the most severe complications that causes sudden death in diphtheria is the toxic cardiomyopathy. And it usually occurs in about 10 to 25% of patients with respiratory diphtheria. And the reason for this is because the receptors on the heart, the heparin epidermal binding growth receptors that are present in the heart, they are suitable receptors for the diphtheria toxin. So diphtheria toxins likes the heparin epidermal binding growth receptors, so it binds to them. So when the toxin binds to them, it causes the death of the cardiac myocytes. So like our patient had a right bundle branch block. So he was already having symptoms of myocarditis. So it is important to know that they usually have complications in their heart. So you want to do a serial ECG once they present, and you will need to keep doing serial ECGs to be sure that the heart is not affected. So myocarditis may be mild, and in some cases it may be severe. For some of them, the myocarditis will appear in the second week of the disease, which is why we had to follow up our patient in a week's time. So we had him come in again after discharge back to the hospital. Then they will have tachycardia, muffled heart sounds, arrhythmia. Our patient had an irregular heart rate already, which is still a sign of some of the complications of diphtheria. So as you're managing these patients, you want to also look out for the heart because the heart is one of the primary places that the diphtheria toxin affects. Usually for some of them, the heart becomes dilated, flabby. There's a characteristic streaky appearance. Echocardiography will show left ventricular dysfunction. Some of them may even present in cardiac failure. So if you see a patient who has cough, neck swelling, and then you're seeing symptoms of congestive cardiac failure, you want to assume that this patient has diphtheria that has now progressed to cause heart failure. You should not treat the heart failure excluding that there is no diphtheria. You should remember that heart failure or congestive cardiac failure is one of the complications of diphtheria. Another thing that they could present is toxic neuropathy. It's important because sometimes the patient presents with the complications rather than the initial disease. So for some of them, they may have neurologic complications, paralysis. They tell you they cannot eat. They can't swallow well anymore, or ocular paralysis. So some of them present with oculomotor nerve paralysis, some strabismus, and in some people, they may have what clinically looks like Guillain-Barré syndrome. So diphtheria can be tricky when you have it presenting with complications. Don't forget to look at the throat. In fact, it's highly advised to look at the throat in children presenting with symptoms like cough, neck swelling, and they are having difficulty swallowing. They are having the voice sounds hoarse. So you want to look at the truth for this. Another reason why we have this toxic neuropathy is the same thing like I mentioned before, that the heparin epidermal binding growth factor present in the peripheral neurons, the diphtheria toxin likes to bind to this heparin binding growth factor. And so that is what is responsible for the, sorry. So that is what is responsible for the peripheral neuropathy that they have. Sorry about that. So, for complications, rarely 2 or 3 weeks after the onset of illness, you could have these complications. You could have gastritis, hepatitis, hemolytic uremic syndrome have also been reported as complications of diphtheria. So the prognosis depends definitely on how well it's treated, the patient's age, the speed of giving the antitoxin, which is very important, the immunization status, the patient's age, and the complication of myocarditis. For people who have severe cases of myocarditis, the prognosis is usually poor. For prevention, of course, in the Nigerian childhood immunization schedule, 3 doses of pentavalent vaccine recommended in the 6th, 10th, and 14th week of life. The WHO also advises to give 3 booster doses during childhood and adolescence. Healthcare workers should also be immunized in endemic settings. So if you're working in a big hospital with an emergency department that is overflowing, you want to get immunized for diphtheria. Take a booster dose for diphtheria. To reduce the risk of diphtheria, the NCDC also says that parents should ensure their children should be vaccinated. As a health worker, please maintain a high index of suspicion for diphtheria. Cases of individuals with signs and symptoms should be notified to the appropriate surveillance officer managed in the isolation ward. Please use all standard precautions while attending to these patients. If you have had a high level of exposure to diphtheria, you should take the antibiotics and then you should get vaccinated. So for case reporting of diphtheria, you should report all cases to the local government area DSNO officer, that is the surveillance officer for diphtheria in that local government, at least within 24 hours. So the key lessons from this case was that any patient presenting with symptoms suggestive of diphtheria, a provision for emergency airway management should be provided. So that was one of the things that ensured that this patient survived. As soon as the patient was seen and in the children emergency, the ENT team was contacted immediately. We did not wait for a full-blown upper airway obstruction. We contacted them immediately to make arrangements for a bedside emergency tracheostomy, which was conducted. Also, healthcare workers should adopt the use of PPEs when attending to suspected cases of diphtheria or any other respiratory infectious disease. So diphtheria is deadly. Immunization is a safeguard. This is just a diagram from years ago that just shows that diphtheria has been a very long illness, long disease that has been with us. So these are my references. Thank you very much for listening to my presentation. I will take questions now. Thank you, everyone. Okay, sorry, before I say anything, I think my chief is here. Let me introduce him. Dr. Emmanuel. Dr. Emmanuel Okegwale, he's the ENT surgeon that did the emergency tracheostomy on this patient, and he was the supervisor for this case. And he will, in case anybody has questions about emergency bedside tracheostomy, that's why I invited him, because I don't know how to do the procedure. So he will be able to give a very good explanation of what it looks like. Thank you very much. Dr. Nilu, I think you're muted.
Hello, can you hear me now?
I can hear you.
Okay, oh, my apologies. Okay, so yeah, I said thank you so much to our speaker, Dr. Etesi, for such a wonderful presentation. I think it was a very good presentation where we got to learn a lot of new things, revise things that we've known, and also to realize that we need a higher index of suspicion for these preventable diseases. So I'd like us to say thank you to our speaker in the chat box or with reactions. So if we have any questions or comments or additions, please, this will be the time to indicate. Any questions? Anything that is not clear, or you're curious about why they did this or did that, or you think that they should have done this or done that, or any other questions you might have, please, we would like to hear from you. Any questions? Okay, I think we might just give like 2 minutes to hear, like, just a short note on the emergency tracheostomy that was done in this patient, if he doesn't mind.
Okay. Dr. Emmanuel.
Good evening,
Dr.
everyone.
Okay. Good evening, Chief.
Good evening,
Welcome.
everyone.
Good
Good evening,
evening.
sir. Welcome.
We can hear you.
Thank you. Thank you, Dr. Anyekan, for your detailed presentation. Yeah, we actually saw this patient, and we're grateful to the pediatric team for inviting the ENT surgeons to come look at that patient and review that patient. And of course, that patient that presented with features suggestive of an upper airway obstruction. Tracheostomy itself is a life-saving procedure and is defined as a surgical procedure whereby an incision is made on the anterior trachea, and then you're sterilizing the stoma via the cervical skin. In this patient, a child, naturally it is expected that this procedure will have been done in the theater. But there are some drawbacks and some other stuff why this procedure wouldn't have been done in theater. One, doing this thing in the theater, especially in a resource poor country like us, for instance, whereby that major theater is what serves every other department. It means that after that procedure, you have to communicate the theater itself. And that may also cause some delay in other cases. But when above that, you want to intubate this patient. In a patient that has diphtheria, there's a problem with intubation because when you intubate that patient, you're going to push that slug further down into the lower airway. And that's what we don't want. In this case, we want to protect the lower airway as much as we can by doing that bedside tracheostomy. And again, the bedside tracheostomy, of course, it comes with its own peculiarities, especially for children. One, you need at least a degree of cooperation from your patient or from the patient itself before you can carry out that bedside tracheostomy, which in a child is close to impossible. But what we did in this case, because this child needed that tracheostomy, if we didn't do that at that point in time, the child probably would have died. I'll quickly itemize the problem of pediatric tracheostomy so that when I'm discussing the steps, it will be easy for us to understand. First of all, in children, the trachea itself is high up, one. Two, it's easily compressible because the cartilage itself is not so mature, so it's easily compressible. Three, because it's easily compressible, there's a chance for it to be forced passage because you just slightly retract the trachea and already you enter into the esophagus. Four, there's also a high chance of forced decannulation. That is, it's not you the surgeon that is doing it, but the trachea, the tube on its own fell off for one reason or the other. And over and above that, positioning itself, because if you don't position the patient very well, some of the structures in the upper mediastinum can even enter into the neck and it cause more harm than good for this patient. So all this in mind, and this the state the child was put into consideration. Now, this child, what we did for this child was one, because we met the child already, it was deteriorating, SpO2 going down. So I called our an assistant, two assistants alongside with the nurse that was with us. The child was placed in a supine position and the neck extended. Now we gave 2% lidocaine, means with 100,000 adrenaline to infiltrate the site that we want to do a tracheostomy. Now in adults, we usually do it 2 finger breadth above the sternal notch. But in children, because of what I've described earlier, the anatomy and all of that, it's usually just 1 finger breadth above the sternal notch. So that area was infiltrated with lidocaine plus adrenaline. And then after, a horizontal incision was made from the skin crease. Then we now retracted because we dissected from the skin to subcutaneous downward, and then we use our retractor to retract. Thereafter, when dissected further through via a blunt dissection, right at the bedside, to the strap muscle, which was bluntly dissected till we got to the isthmus. And then for me, some people advocate you dissect the isthmus. I don't do that. What I do is to retract the isthmus, and I get the trachea. Then you count the trachea ring, because as much as possible, it's best to do a mid tracheostomy. That is, which is just around the level of the isthmus between the second and third trachea ring. Now, when we got there, skeletonize and then instill some lidocaine into the trachea so as to decrease the cough reflex. But because it's a child and there's this fear of forced decannulation, we have to put a stay suture around the trachea with a nylon so that to hold this trachea in place, should in case that the tracheostomy tube falls off. With the stay suture, you just pull it out again, it opens the trachea for you, and then you reintroduce the tracheostomy tube. And that's what we did for this patient. Use a stay suture, then confirm it, instill the trachea to create cough reflex. Then we now have to make a vertical incision between the second and third trachea ring, then introduce the tracheostomy tube. And it's pertinent to note that most times, what we want to do in the first 24 hours is to use most times a single lumen tube, which is of course more available for children of that age. And then we instill that, then place it into the place the tracheostomy, single lumen tracheostomy tube, then suture, and then close, and then suture loses to prevent surgical subcutaneous emphysema. Now, after that, we've done that for the patient, and of course, with adequate monitoring, because we're doing that, the FPO2 machine is close, the multi-parameter ventilator are making progress, bearing in mind that this child is high oxygen in children because they have little reserve. And if you don't go with speed, also, the child may not be apneic and then may continue an autopsy instead of even doing a procedure for this patient. Now, having done this for this patient, and then we've monitored and then we've secured the tracheostomy in situ, then we have to now strap and then put a lay foam suture, lay foam dressing on the tube. Having done that, the next thing we want to do is, remember that this child is in an isolation room because of the nature of the illness of the disease itself. But then, in this case, because this child has not had tracheostomy, the child with tracheostomy can no longer talk, cannot cry. So this child must now be placed and be nursed directly opposite the nursing station. What we do here is nurse in sight and in sound. So I leave a little sound because this is a single lumen tube. There's increased rate of secretion, can get blocked. So for that reason, it will just be directly in front of the nurse's bed. So they can always put an eye on the patient. 1. 2, we also want a bell to be just close to the patient. If not, because the child is a child cannot help. But when the mom staying with the child notice anything suspicious, can also ring the bell. The nurses are not there, can come attend to this patient. And then other things which is common, which is a social machine. Remember that this child has a tracheostomy tube in situ. If you watch everybody, see that in the nose, one of the functions of the nose is to humidify air. But that humidification effect of the nose is lost. So dry air directly will hit the trachea. And this on its own, am I still being heard? Hello?
Yes, we can hear you.
Okay, thank you. This alone cannot increase the level of secretion itself. And then, so the suction machine must be closed, which you say suction PRON for this patient. Apart from that, there's also room for sodium bicarbonate too, which is also a decrusting agent, which can also be used to moisten this crust and then make it easy for you to suction this patient. Now, one of the other things that we also do for this patient is we'll deflate that cough for at least 5 minutes every 1 hour for the first 24 hours. Because if you don't do that for this patient and you put that cough, remember that there are some vessels around. Continuous pressure around that place could lead to pressure necrosis. I would not want that because we'll be adding another additional morbidity for this patient. And this we did for this patient, and thankfully to God, the child got better. And after like 72 hours, when we believe that the tract has been formed, the single lumen tube was not changed to a double lumen tube. And then the patient improved. The bull neck that the patient had suddenly subsided, and then it was fine. After that, of course, we have to do do X-ray of the neck to first of all confirm. Immediately after it to me, do X-ray of the neck to check to confirm the position of the tube itself. But in this patient now, who has done very well, I think on the 5 disease, between the 6 and the 7, we have to now commence on decannulation. Decannulation now is a process of gradual weaning off of a patient of tracheostomy after the indication for which tracheostomy has been done has been met. In this patient, we had tracheostomy because the features suggested of an upper airway obstruction. Now, the child is not breathing well, tolerating orally, the neck swelling, everything is reducing, and of course, clinical signs and symptoms are not fine. They will say, okay, this child has met the criteria for decannulation. Quickly, let me talk about decannulation itself. There are mainly 3 main processes of decannulation, which is downsizing of the tube, occlusal method, or surgical decannulation. Now, the last one is surgical decannulation. Is common among children because they are they get breather also, and some of them, because they keep breathing with they get used to the system itself, and then they may not be able now to breathe by themselves. So what we'll do, we'll take them to the theater, and then gradually, and then maybe cannulations around, take them off, and then gradually put an ET tube for the patient, and the patient has to breathe until the ET tube is moved. But come on, this patient, we did occlusal method. In occlusal method, the tube itself is still, I want to talk about it, it's still in place, but you cover the whole of it, both the tube and everything, you cover everything together for at least a minute of 12 hours. What we do here is we do it in the morning, maybe 8 o'clock till 8 p.m. And at that time, everybody is still around. So that in case the child does not tolerate that decannulation method, we will now be able to intervene. So the multi-parameter method is put in place. The nurses are informed, and then we occlude that tracheostomy to put that opening, we cover with a dressing, and then occlude everywhere. And then we're looking at the vital signs to see if the pain is going to saturate or if there's going to be a change in the vital signs. And then we'll monitor like that. And if at the end of the day, about 12 hours, the child tolerates it, then the next thing we'll do is to do a 24-hour occlusal method. And if after that, the child also tolerates it, then it is now safe to remove the tracheostomy tube. And in this patient, with the occlusal method alone, the child, we didn't need to do a downsizing method. We occluded, and then the child got better. And of course, child was discharged from ENT care, and then the pediatric unit continued their management. Thank you.
Thank you, Dr. Emmanuel.
Thank you so much, sir. That was very insightful. Providing perspective on airway management in patients with diphtheria. And we have a couple of questions for our presenter. Okay, so I'll read out the questions. Okay, sorry, let me begin from the first one. Yeah, okay. So Miss Olubuchi says, are there IV options for these patients since azithromycin seems to be the first line? And to add to that question, I noticed during the presentation that you said that the patient was placed on IV amoxiclav and metronidazole, and then the WHO guidelines are azithromycin or erythromycin, and then the penicillin options did not include amoxiclav. So I'm just curious as to why the management team decided to give IV metronidazole and amoxiclav in this condition to that patient. So please, can you respond, Dr.
Okay. So I think one of the important things I should say is that there is an antibiotic sensitivity based on region. While the WHO recommends azithromycin as first line, erythromycin, penicillin-based antibiotics, penicillin V, as the case may be. In our center, we found that IV amoxiclav did very phenomenal job. Of course, based on that pattern, the consultant pediatricians in infectious disease and the emergency decided that should be the first line. And of course, they had recorded progress, or they had been recording success with managing the infection with IV amoxiclav and IV metronidazole, and that's why they stuck to it. So I think it's a center-based thing where they had tried it and it had worked. Also, I think definitely. So that would be the answer to that question. The hospital's profile has showed that there's a lot of sensitivity, that they had a lot of success with using IV amoxiclav and IV metronidazole. And so definitely they decided to go with that. So that is like something of priority, what you prefer to use. Some centers may prefer to use penicillin, but I think IV amoxiclav is more easily gotten. It's more easily affordable and easily gotten. So the accessibility of it was also a factor. And since it does the job, definitely they decided to go with that.
Yeah, I think that's great. Taking the peculiarities of the community where you work into consideration. Yes, the next question says, please, what is the prophylactic dose for erythromycin?
Yes, Chief.
Okay, sir.
Okay, thank you so much. For us, it was actually the ENT team that actually started by adding this augmentin, that's called amoxiclav and metronidazole in the unit. Diphtheria for us, again, is also one of the differential diagnoses of membranous tonsillitis. Of course, apart from diphtheria, there's Sedagena, infectious mononucleosis, Candida and trauma, acanthocytosis, and all of that. These are all differentials. So, from the first what you said, from our own, we have a culture here for all these things. Our this environment to this
Sorry, Chief. Am I the only one that cannot hear him
Sorry,
well?
yeah, your network is breaking, sir.
If your network is breaking, we can't hear you.
We can't hear. Hello, sir. We can't hear you, sir. Your network is breaking. His network is very bad.
I'm not sure he's even hearing us.
Yeah.
I don't know how we call him.
Oh, I think the network has even logged him out completely.
Oh, yeah.
So hopefully he joins us again. Yeah. So I think you were about to answer the question about the prophylactic dose of erythromycin.
Okay, for erythromycin, the prophylactic dose is usually 250 milligram 6 hourly. But some people say you can do 500 milligram BD, but the essence of 250 milligram is to maintain a continuous concentration of plasma concentration of the antibiotics in the body over a period of time, and it's taken for 7 days. So you take erythromycin 250 milligrams 6 hourly for 7 days. I know it seems like a lot of work, but it's better than having diphtheria.
Yes, definitely. Okay. Someone else is asking that when do we stop the serial ECG for a patient being monitored for toxic myocarditis?
Okay, so the first thing is that if the patient has been managed inpatient-wise, you have to do, I want to say at least twice a week, but based on the facilities we have and based on the patient's finances, you may opt for weekly ECG. So you will do weekly ECGs until discharge. After discharge, you do serial monitoring. So every week, the patient is actually supposed to have an ECG weekly for 6 weeks, or until you discover that there are no longer any signs or any ECG changes or features suggestive of myocarditis. So it's usually 6 weeks. But like I said, it's dependent. If at 6 weeks you still observe that there are still some minor changes, you may still have to continue the serial monitoring of ECG.
Okay. Hopefully one of these days we'll not have to always include resource limited setting when we're talking about Nigeria.
Yes.
Okay, so we have some hands raised.
Okay.
We have Mr. Jackson. Please, Dr. Jackson, please ask your question. Thank you.
Thank you very much, Dr. Oyelua, and thank you very much, Dr. Anoka, for a wonderful presentation. I have a couple of questions. So the first question is more about The question is, you mentioned that the the index patient along with two siblings had similar symptoms, and you also mentioned that the patient was said to have been adequately realized for AIDS. So I want to know, was a history gotten from the parents about the other siblings? Were they also immunized? And especially for the one that died, the 4-year-old, was she being that she's the one that would have been more recently realized? Is she adequately realized for AIDS? Also, would it be possible to have like a follow up where if possible, we can get the immunization card for the this type, this investigation, check and probably factors that we have put that the infection still happen. So the second question, you mentioned about
Wait, sorry, please, can I still be heard?
We could not hear you for like maybe the past 30 seconds. Yeah. But I heard where
Oh,
the second question of if the child was whether the sibling was immunized for age and if we could cite the card, something like that. But I lost you after that.
yeah.
okay. So I was saying that would it be possible to um trace and get the immunization card to see if the child was adequately immunized? That's probably got the 3 doses, and I know the patient likely did not get booster doses and all, but at least those 3 doses at the 6th, 10th, 14th week, would it be possible to check and get and see if this patient actually got it? Maybe it could actually be a good research topic or something, maybe a case study series or something. Then my second question is about the culture. I think you mentioned something about the culture not yielding any bacteria. So I want to know, like, what could have been the problem? Is it maybe there was no appropriate cultural media, or the sample was not collected correctly, or is it that the organism is just difficult to culture or something? Then my last question, I just want to know about the follow-up, like how many weeks was the child to come back for review, and how is the child doing? Basically, just that. Thank you. Thank you
Okay.
very much.
All right, thank you very much for that question. I think your question demonstrates the way that emergency physicians should relate with public health, because I think an emergency physician would definitely have to have some public health knowledge, no matter wherever they are working. Okay, so for the first question, for our patient, one of the things the mother said he was immunized for age, that he received every of his vaccine. Well, I don't know about the child who died, but I can speak for the patient himself because that was the patient under my care. So the patient himself, yes, the mother said he was immunized for age, but we did not see the vaccination card. That could be as a result of this child being 10 years old. So if they had moved house or something, they could have lost the immunization card. But what I want to say, what it draws importance to is the effectiveness of vaccination. We have several cases where children go for vaccination. Maybe they are supposed to take 3 vaccines that day, and there are only 2 vaccines available at the health center. They would say something like, the nurses would say, "Oh, we don't have this vaccine today. You would have to bring your child tomorrow or in 2 days' time for us to vaccinate." But they will mark the MPI card that the child has been vaccinated, but they will definitely say, "Oh, come in 2 days, we don't have this vaccine." In some cases, those who do not mark will say, "Come in 2 days." But the parents do not go back because they feel, what's the difference between taking 2 vaccines and taking 3 vaccines? So it is just, it goes back to what I'm saying, that we are seeing a resurgence of diphtheria because they are under immunized. So you have somebody who has taken the first dose, the second dose, but missed the third dose. He could have missed the third dose because of health worker, the health facility fault. That means they didn't have the vaccine in store. Another thing to consider is if the vaccine is not stored properly, the vaccine could have been inactivated. And this patient is just taking normal, I don't want to call it normal saline. So you could have a patient that is taking vaccine that is not working anymore. So, because I've seen a situation where the vaccine vial monitor on the vaccine is saying that the vaccine is no longer good, but nobody wants to throw it away. They just want to manage. Let's see how we can panel beat it. These are some things that could happen. So, a child could have even received all doses of vaccine, but he was taking vaccines that were not properly stored. So, the vaccines are inactivated. It could be a situation. So for this child, I think the parents did their due diligence because they mentioned they vaccinated their children. You can see that they actually presented early at the hospital 2 days after he had the cough. Once they noticed the neck swelling, they took the child to the hospital. The issue lied with the hospital itself being able to manage the patient appropriately. I'm not sure they knew it was diphtheria. And it goes back to talk about the fact that some of our private facilities really need to do a lot of homework. So yes, that is what my answer would be for that case. To find out if this child was vaccinated, if we had electronic records of vaccination, so you can easily retrieve or check a database to see if a child was vaccinated, I think that would have been possible. But of course, it's not possible currently in Nigeria. So yeah, still shows that we have a long way to go. I
Thank you
don't
very
know if I've
much.
answered all your questions.
Oh, thank you very much, Dr. Edison. But the other two questions, the one about the culture and then the follow-up.
Okay, so for the culture, I think a poor sampling technique was used. It's not that they did not culture, they did, but they cultured normal flora. So they saw a gram-positive bacilli, but it showed that the culture was it was a normal flora that was cultured. I think the problem was the sample collection. Another thing could have been that the sample was misplaced. Another thing could be sample contamination. There are so many reasons in that chain of events. And the reason is because we're in an emergency department. And of course, the best persons to have collected the sample is the WHO team. That's the truth. Or we call directly the microbiology unit, which we did. We called them that day while we had already taken the initial sample before starting antibiotics. We took our sample, we still call the microbiology team so that they can follow the best precautions to take it, and we still call the WHO team. So I think for this case, it's also a reminder of who is collecting the sample. I think there should be a training for proper sample collection, especially for cultures, because most times you would take a sample from a wound and any other this thing, and you'll be culturing normal flora. So I think it's an issue of sample collection. It wasn't properly collected. However, we later had a microbiology team who came specifically and took the culture, and then the WHO team came on the fourth day to take the culture. For the follow-up, the child was followed up at the infectious disease unit. This child had some mild myocarditis because we saw regular pulse rate, and we had a right bundle branch block on ECG. So the child was followed up at both the infectious disease clinic and at the cardiology clinic, was followed up. So he was supposed to come with an ECG a week after he was discharged. So the child presented with an ECG at the cardiology clinic a week after discharge, and then he was managed from there on. I can't go to say how he was managed because I didn't follow up to that point. I can only say how he was discharged. Thank you.
Thank you very much.
All right, thank you very much, Dr. Edison. I think we have one more on the list. Dr. Elam.
Okay. Hello, good evening, everyone. And
Good
thank you
evening.
so much, Dr. Ali, for the wonderful presentation. I think we can confidently say we have become experts in managing diphtheria outbreak in IPC, and as well, the most important thing is in upper airway management. This is very timely. Thank you so much. It's really a wonderful presentation. And just to add something, I think one of the key things I would like to talk about is the antibiotic management. it's actually based on local center sensitivity. Usually, this is what is being followed. And the recent Nigerian Center for Disease Control guideline, or based on the cultures taken from the 2023-2024 outbreak, the main sensitivity is determined to be erythromycin, the first line. And what was originally recommended is IB erythromycin, which is very difficult to get, not readily available. So we normally use IB azithromycin. And if that is, as soon as patient can tolerate orally, we convert to oral erythromycin, or we can use oral azithromycin. And the treatment is to be completed for 14 completed days. We can start with IB, then switch to oral, or vice versa. So, but for 14 completed days, and the contact obviously can be treated with preferably erythromycin or azithromycin. And we usually prefer azithromycin because it's a once daily dosing, and they can take it for the whole 7 days without any loss to follow up or something like that. So these are some of the things I wanted to add with regards to the antibiotic. And for people like us working in remote centers, in case you had a patient that's presenting with diphtheria symptoms, and you are thinking that that patient may likely have airway obstruction, one of the likely things you will see in the first instance is probably going to be stridor and the bull neck. Don't wait till it gets to the level where you will start calling for ENT surgeons. Yes, Dr. Emmanuel will be very happy to come and help us. But then I think one of the key things recommended is the use of corticosteroids. Most advisable is IB dexamethasone at 0.6 milligram per kg loading dose, then 0.1 milligram per kg 6 hourly. This is very effective in reducing the bull neck, the pharyngeal and tonsillar swellings to relieve the airway, the upper airway. And it's very good in remote centers where you don't have facilities to do this tracheostomy, And you could also use warm saline gargling in case you don't have the 1% hydrogen peroxide solution. So that's another important thing. And be on the lookout, because one of the likely things that may kill your patient is either thrombocytopenia with bleeding from multiple orifices. Sometimes you may be confused whether it is Lassa. Don't worry, it's not Lassa, it's just thrombocytopenia. And patient may also die from cardiomyopathy. The other important complication is neuropathy or paralysis, which usually come 2 to 8 weeks after the infection. So, and it usually resolves. So neuropathy usually resolves on its own spontaneously. You only need to monitor, maybe do some rehabilitation and counsel the patient. However, cardiomyopathy, thrombocytopenia can easily kill your patient, as well as upper airway obstruction. These are the common killers in diphtheria. Yes, one of the key challenges in Nigeria is data, And I think in the previous outbreak started ending 23 and to almost most part of 2024. And I myself in Kasina, then we managed over 7,000 cases. So, Dr. Oni, your data, maybe WHO or NCDC is using the confirmed cases they isolated in their own lab.
Yeah, The confirmed cases are laboratory confirmed. So it may be that suspected cases includes that whole number. Yes.
So it's way past that. In Kano, my colleague was telling me they manage over 11,000, and this is just what they manage in the facilities, because there is a single dedicated center for managing diphtheria cases, which was established in Kano then. They manage over 11,000, and most of these relatives, just like the history she presented, most of these patients will come with a history of 2-3 relatives having the symptoms. At least one would have died. That's common presentation of diphtheria. At least one will have died. And one of the worst things that happened in Kano then, was the rampant cases of adult patients with diphtheria. Very severe and very terrible form of diseases in adults. You will see 40-year-old, for something year old, 50-year-old coming with diphtheria, and usually used to be terrible. And these are people that will have been going around, disseminating the disease, transmitting to other children, other people, and it's just so terrible. And yes, one of the significant drawback we notice in Kano then is immunization. Penta vaccine, which contains this diphtheria, is usually the most common one that causes fever and some other reactions in children. When you give them the immunizations, they will be crying, having that fever or the mild reaction the children used to have after receiving the immunization, so they don't complete it mostly. Even if they go for the immunization, they will say don't give them the vaccine that causes that fever or that reaction. So because of that, like bad experience, they don't normally follow up or complete the Penta vaccine. You are supposed to take 4 doses of Penta, and it's one of the isolated vaccine that has a very low what do I use? How do I put this? It's one of the vaccines that was identified to have very high loss to follow-up rate, if I could put it that way. So yeah, it's really important we advocate on that. And the terrible part is currently we are still having another outbreak of diphtheria. I think it started around ending October. In Kano, we have re-established mortalities. So it's really a terrible disease, and we should be on the lookout. And one other thing that we don't normally do, especially regarding the contact tracing, is checking for history of similar symptoms, especially among classmates or playmates, or neighbors, children in the neighborhood, even adults. And it's one of the important things that we should identify and place anybody with contact to such particular cases on prophylaxis. Yeah, I think these are the few important things I wanted to add. So yeah, thank you so much, Dr. Annie, for the wonderful presentation. It was really amazing. You did absolutely well. And thank you, Dr. Emmanuel, for being with us to give us this wonderful knowledge on how to do emergency tracheostomy. Thank you.
Thank you so much, Dr. Borazak. That was very insightful, providing some on-the-ground perspective regarding diphtheria management. So I think we have addressed. Okay, someone was asking if IV azithromycin is readily available. Dr. Abdurazak, can you respond to that, please? Okay, he said yes. All right.
Yes. So actually, both erythromycin and azithromycin are difficult. But I don't know, based on the setting I worked with, a lot of organizations tend to support this outbreak. So we have azithromycin more readily available than erythromycin. So yeah, it's actually available. It's available.
Okay.
I think Dr. Lawan, that would be your where you are, because it's not that available where I am. All right.
Oh,
yeah, I think it's
sorry
based on
about
the fact that I think it's based on the fact that they're actively managing so many cases.
So many cases, so they have to
yeah,
stop. Yes.
exactly. So providing the IV azithromycin is like it's a priority for them in those kind of centers. So yeah, it's understandable. Okay, so well, thank you so much, our wonderful presenter. I think this was a very insightful presentation. And thank you even more to all the members of EMIG who were here from beginning to the end, and those who also left at some point during the presentation. Thank you also to Dr. Emmanuel for your presentation on the emergency tracheostomy. I'm very certain that we've had a very wonderful experience, and we are all looking forward to the next case presentation. So thank you so much once again, and have a wonderful weekend. Bye, guys.
Bye. Thank you, everyone.
Thanks.